for a change, rather than on Tuesday, on a Wednesday morning, I'm doing it on Friday. So that after this lecture, maybe you'll have one more lecture, right? After this, you have one more lecture, or
Of what? Head and neck?
whatever the lecture after.
Of the day.
No.
Oh, the day? This is
So then it's a party time, right?
Yeah.
Yeah.
National Night Reading Day.
Same thing.
Yes.
So what is that you guys are studying for? Immunology. Oh, okay.
It is.
Okay, so this is guys. Here is the deal. If you can cooperate, I can leave a little early so that you can go and study or party, whatever you guys want to do. Right? I was just told that after this there is no session. Generally, I leave at 2:50, right? Maybe 2:49.
49.
Yeah. 1:49. Then yeah, I can leave you at 1:49, but you have to study on your own.
Yeah.
That's the second year.
I think you can teach us this.
Yeah. Okay. So here, this is a nice thing that I think myself and Dr. Landis we tied together this lecture. Since you have anatomy, now if you look at three-dimensional imaging, can you correlate with that anatomy and what you are seeing today? So we kind of started this program like 3-4 years after I came here. It's going so far very nicely. So this may be like a little dry, like radiology or physics, because what I'm going to talk about Ramus, what I say condyle, head of the condyle is head of the condyle. It's not going to change. So it may be a little dry, but what I have done in this particular lecture is three things. That there is a dry skull image that you can compare, and then you have a panoramic radiograph image, and then a CBCT image that you could look at those three and identify the structures. So why is that we are doing this kind of pattern is because now you have anatomy, right? And you can correlate very easily the things. And down the road, those who wants to go and buy CBCT machines and practice with CBCT machines, it would be helpful. So we are giving you very early solid foundation. So what is the outline? So we'll talk about imaging modalities that are commonly that is being used in dentistry. And then multi-planar reformatted, or most commonly we use the term as MPR. So multi-planar is like 3 views that you can visualize using the scan. For example, coronal slice, sagittal, and then axial slice. If you look all the 3 slices, then we call that as MPR view. Then we'll go through the anatomy like maxilla, mandible, and some facial bones, and a little bit of cervical anatomy.
I put it on the class drive under unfinished lectures. Was anyone able to see it? Because Stella said it doesn't come up on hers, but I have it on here. It might be because the files, it's a very large file. It's too large to send via email.
Can you put it on Google Drive?
Yeah, I put it on the drive, but it's for some reason it's not showing up for them.
What should we do now?
Continue.
Just continue, right? Yeah. Don't worry about others, right? Yeah. Okay. Early dental radiograph. So, if you look at that topmost right-hand side, that's the first dental radiographic image that was taken. So, it took almost like 20 minutes to get that particular radiograph. I think I may have showed this radiograph or this picture in your other area. Yes.
Is the
Is the long time the reason there's so much noise?
Because,
Took so long to
because we
develop?
didn't have a very good receptor.
Okay.
Because the only thing that has changed from that time to now, like 100 years, is only we changed receptors. The projection geometry, everything is pretty much the same.
So if we take a radiograph and we get noise, that's the problem.
Problem could be one is because using low EMA.
Oh, okay.
Or if the patient is really chubby, and then you are using low EMA. And if there is a defective or faulty receptor.
Okay.
And this is how the dental X-ray units were looking at the time. As you can see, the wires here, they are pretty open. So when they were handling, some of the people touched those wires and died. So now we have got fancy coverings, everything, right? The only thing that has changed here, as I was telling to Brian, is X-rays are released and you release that X-rays to the object, and the receptor is the only thing that has been changed. For instance, we started off with films, like from A all the way to letter F. That's where we stopped. Eighth of speed is EKATA. That's what Kodak used to produce. And F speed film. And then some extra development came, like PSP plates or phosphoplates. And then what we are using in the school is direct digital sensors, which we discussed last week, right? Digital sensor, CMOS, CCD. So now you can see the difference, drastic difference between that particular radiograph and this particular radiograph. Here you can identify and say, hey, this is pulp. If you ask me where the pulp is, all I could say is they have teeth, right? And I can't identify the dentin. It looks something. Yes.
So what was the use and purpose for the older radiographs?
Good question. So they started off with something, you know, and then they made a lot of improvements because they wanted to see more and more. And dentistry was the first branch to adapt radiology. And then medicine followed that, which is weird, right? And now they are so advanced, we're still behind that. And then the next advancement that came into radiology is panoramic radiographs. So it was in 1950s and 60s. So this is how a modern machine will look like. In older machine, like here, if you see, the patient used to rotate, or the chair used to rotate, which is funny, right? Now the advancement is the machine will rotate and we'll get an image. So it takes like 15 to 20 seconds. Okay. Another thing that I would like to highlight here is a lot of people, they tend to use the term something called as panorex. Panorex is a brand name. For instance, like when you use a tissue, like a paper, facial tissue paper, it's like we have a Kleenex, right? It's like Panorex is a brand name. So when you're in professional world, we don't generally like to use any brand names. That means you are promoting. So it's better that you use a term called as panoramic radiograph, or if you don't like that panoramic radiograph as a very big name, you can call as PAN, P-A-N, PAN, or PANO. Okay. And if you're going to talk to older clinicians, they say, hey, go and get the Panorex. So because they are used to that brand. And then, till late 2000, early part of 2000, we didn't see any advancements. Although there was a tomography that came, it never actually came into full commercial use. So what was the problem with the 2D imaging? Is that there will be some superimposition. Like we taught in the panoramic radiograph that because of the projection geometry, there will be some superimposition happening. For instance, like this one, which I think you may have seen, and this one, right? So it's hard for us to tell if there is a superimposition, especially when we are dealing with a diagnostic process. And I'm not sure I shared this video with you guys, but let's see if it's going to work. So nice, beautiful car from behind. So that's exactly what is going to happen. So if you're taking an image from behind and if you're projecting, then there is a chance that it could be diagnostically challenging or completely obscure information that which is not helpful for us. So this is one brand machine, Sirona. So it is like, yeah.
To your point, if you have a tooth, if the caries is on the front or on the lingual side, you're shooting x-rays this way, how can you tell whether it's on the facial or the lingual?
That's one of the reasons we don't use panoramic radiographs to identify dental caries. We look at the gross abnormalities, like if there is an impact or if there is a fracture. So when I taught the panoramic radiograph, I never discussed with the dental caries. It's because it's hard and it's challenging because we don't know inside. So back to here, the panoramic radiograph is you would see the patient in the machine and it's going to circle around the patient's head like 15 to 20 seconds. Again, depending on the brand machine and depending on the amount of radiation you are going to give, it could be different. But on average, it's like 15 to 20 seconds. And it's going to take number of ceph-like projections. And then they will combine together to form a CBCD scan or a volume. Like here. So here you can see all the three dimensions. It looks like I always try to correct the sagittal. It's spelling here is mistake. It's double T, not double G. So I don't know why it reverts back to that. So here is the sagittal view. So the best way, I think I would remember the sagittal like letter S and like side. So if you're cutting like this, like sideways, that's the view that you're looking at, sagittal view. The other two views, I have not come up with any good analogy. So if you have some analogy to remember, please tell me so that I can pass on to next generation of students. So axial is basically you are cutting off like this. And then here is an axial view of mandible, and that's the axial view of maxilla. And coronal is like here chopping off in this direction. So within the axial view, when you are using the terminology, we use this terminology like anterior and posterior, and right and left. So remember, whenever I give you an image, this is always axial especially, and coronal is right side and this is left side. Okay? Because you are looking at the patient side. And again here typo, sagittal, you can see here we use the terminology superior, inferior, anterior and posterior. And when you are dealing with coronal, we use the terminology like superior, inferior, right and left. So why do you think I'm stressing so much here? It's because when I write a report, I'll say in my report, if there is a pathology, it is in the coronal slice. It is extending in the superior, inferior direction, the lesion. And in the sagittal view, it is located inferiorly to this. So you should understand what the hell I'm talking about, right? Because if you want to do treatment, you should know where it is located. Is it above the inferior alveolar canal, below the inferior alveolar canal? Is it right to it, left to it, and by how many millimeters? All those things, when I give a report, it's going to be helpful. And also not only that, when you want to talk to another dentist, they will understand this language. So again, within the axial slice, you have a buccal and lingual or facial. That's the terminology that we tend to use. So when we take a CBCD scan, we capture, depending on the volume. When I say volume, it is nothing but how much amount of the structure that you are trying to capture. It could be 15 by 15. So if you're going to become an orthodontist, or if you're going to become an oral surgeon, then you need to capture from here to here, the scan. But if you are going to become an endodontist, then you are concerned only with one tooth. So you don't need to know the whole of the anatomy, right? And you're looking at the scan, and you don't want to buy a machine that's so expensive, and it will capture all the views. And if you're going to place implants, at least you need to have a machine that captures 8 by 8, so from here to here. Because sometimes you may have to place the implants in the maxillary region or in the mandibular region in the same patient. So at least you need to have 8 by 8 volume. And those who are from Canada, anybody from Canada? Nobody. Okay, so in Canada, especially in Ontario province, they can buy only 9 by 9 machine. Anything above, the radiologist will take over. So when we capture that kind of image, we need to know a little bit of anatomy, right? Let's start with maxilla. So what view do you think is this one? Sagittal, wonderful, okay. Now, if I ask you to identify what is the abnormality that is so striking in this image, can you be able to tell me? Or at least you can give it a try. Yes.
Are we talking about the anatomy of the tooth where it's abnormal, where the...
I'm just asking the question, what is the abnormality or that's variation of normal that you're seeing?
I feel like there's no overbite, there's no anterior guidance.
Okay,
Nice.
good, very good start. Okay. Anything else?
Is there something in the maxillary sinus?
Something in the maxillary sinus, okay? We'll come back and discuss about that.
Is there mandibular elongoma, or I feel like we haven't really seen the sagittal view of X-rays at all to know what it's supposed to look like, but that looks a little weird to me.
Where exactly is it looking
The
weird?
root of the mandibular, like.
So when you say brood, you're looking here, or are you talking about this right
Oh,
here?
is that, I don't even know where it ends, I feel like I've never seen a sagittal X-ray, but, I don't know, it just looks weird.
Here?
Yeah.
This one? Okay. Anything else?
I was gonna say, I kind of, I don't, maybe just me, but it kind of looks like it's a fracture maybe or something.
Where exactly is the fracture? Can you point to us? That's very difficult. So, here?
Oh.
Are we talking still here?
Oh, okay,
This-
never mind.
This region or somewhere else?
Somewhere else, but I think it's probably just,
This one?
no, don't worry about it.
Hey, I'm trying to.
No, like in the middle.
In the middle.
Yeah.
Oh, okay.
And then it like goes back. I don't know what that is.
So you, is this one?
No, lower.
Lower.
Yeah, right there. Oh, the other
Why
one.
don't you come here?
Oh, okay. Yeah, why are you mad at it?
You're helping all of the students, including me.
Okay. I was just looking on here. I don't think that's anything.
So, what's your name?
Sure.
George. George from 3.
That's me.
Okay, so that's the ventral part of the tongue, that's what he's showing. So I'm here to clarify the doubts and enhance your knowledge. So please feel free to ask questions. It's not the quantity that I'm trying to deliver here, the quality. Even if you know few things out of 100, I'll be very happy. Because anyways, as you move, then you'll start connecting the dots, then you'll be competent enough to look at all the images. Okay? But you have to start somewhere. So now, somebody pointed that there is a lack of overjet and overbite. So when you take a CBCD scan, we ask them to bite on the bite guide. So is this the ideal one? Answer would be no. Yes. And here you can see the tooth, and because of the slice, you are losing that transition here. Because sometimes the tooth may be in this plane, or if the tooth is like this in this plane, you are going to miss because you have slides in a different fashion. So you're not able to see completely the tooth structure. That's why you're not able to see the root portion completely. So again, that's one of the reasons that you have to look at the scans completely, because you need to know the anatomy, how it is looking like. Yes?
Why do we only see 2 teeth in the sagittal view? Why aren't we seeing other teeth?
So if you cut at exactly at the midline, you're going to see only the centrals, right?
Oh, so you're seeing it from here and not from here?
So, like this one.
If you sagitally slice the head.
So that's number 9 and number 24?
Yeah.
No, I see.
Or it could be 8 or 25.
No,
Because the
So again,
is
you need to
minus-
correlate. Here, what you're seeing is the incisive canal.
What about the posterior teeth? Why did you see that?
Because they are not captured in the slides, because the arch is like this, right?
Yes.
And you're chopping here at the center. So, say for example, okay. So imagine this is your arch, right? So if you take a slice here, you can see the posterior teeth. And if you take the slice at the center, like this one, you're not going to see this portion because you're only checking this part. And we are doing a slice thickness only by 5.5 millimeter or 1 millimeter. And if you take a thicker slice, probably you'll see it. Make sense?
How
So-
does the radiograph take a slice and not see, is
No,
it
no,
not
no.
blocked by everything else?
Again, when you're looking at the anatomy, you're going to look by slices only. You cannot look complete picture. That's the beauty of this CBC. So imagine you have a bread, right, that you get. So you imagine you're slicing it off. And take a picture of that and cut it. And take a CBCT scan around that. You could miss some portion. Make sense? If not, don't worry at this point. So when you take a slice, depending on the slice, you could capture only few structures. Many structures may be missing. Yes?
I guess our question is just how can we take the slice without like anything blocking in the middle? Like where do you put the source and the receptor that you can slice just one piece and then the other, like the posterior tears is not blocking the, do you get what I mean? Like how do you
Yes,
slice
yes.
it?
We need to go and read more about, there's something called back projection geometry, so how these computers will work to get a good image. If I teach that, everybody will fall asleep here. So let's pretend we are not going to talk about that at this point. So computers will work behind the screens. So you can look only what you want to see. So depending on the slice. So Slice is a part of volume. So imagine this is the whole volume, but if you want to look only one part, you can still see. So what I've done is out of this whole thing, I took one slice and put it here. Make sense? So couple things. Here is the tongue. This is the soft palate, a hard palate here, and maybe tooth number 8 or 9, and 24 or 25. I need to double check. So here, this is the tongue. And what is the space between tongue and palate is called as? Palatoglossal space. This is what you are seeing, palatoglossal space. Space between tongue and the hard palate. And what is this space? And this is? Very good, okay. So here, there should be at least like a 5 or more than 5 or maybe 10 millimeters of gap should be there. If it's not there, so that means this patient may have a sleep apnea or could be a precursor for sleep apnea. Patient might be snoring during the night time. So how can I tell? Because there is a reduced airway space. The most important thing here is, look at this particular image. What do you see the difference between earlier image and this image?
There's a bigger glossopharyngeal space.
Incisive canal is not as clear.
Okay? So somebody said to me that they were not able to see maxillary sinuses, right? So here in this view, you can see clearly the sinuses or part of it, right? So again, remember, depending on the slice, you could miss some structures, or some structures are visible only in few slices. So what structure do you think is this one? You guys had anatomy dealing with a nasal cavity. Somebody said that. Can you?
Inferior nasal contract. That's the inferior nasal contract.
Turbinates, yes. That's the inferior turbinate, that's what you're saying. So this is the middle turbinate. Good job, yes. See, what I want you to focus is this particular portion here. So what structure is that? Starts with letter P. Pituitary, right? So, do you know the normal size of pituitary or sella? Testicle? In Turkish it is called a saddle. Turkish or Latin, whatever the language. Maybe Latin, right? Yeah. So, generally if it's less than 10 millimeters or 1 centimeter, it's considered as normal. So here, as you can look, it's 60 by 21, so that means huge, right? The other thing that you have to check is, you can see there is a white line here, right? And there is a white line, but you are not seeing this white line. But there is also like something going on. We talked earlier, I think in panoramic radiograph, the air-filled sinuses should look black. Because they are air-filled, X-rays can pass through, right? Can you see the sphenoid sinus there? This is the sphenoid sinus here. Part of it is filled with soft tissue. Part is air-filled. And there is a breach. So, if there is a pituitary adenoma, what it is going to cause is it's going to enlarge, and then it's going to take away that bone that is present below, and it has penetrated even into the sphenoid sinus. So now, teeth are the least concern at this point, right? So when you take an image, probably you are going to see not only the teeth, but you are going to see other structures. And then, depending on how comfortable you are reading, you could read by yourself or you can send it to a radiologist like me. We can read and provide you the reports. Okay? Remember, when you take image, it is your responsibility to read and provide a comprehensive treatment plan. Or at least you can say there is some abnormality which I'm not too comfortable, I'm referring it to the physician to take care of. So having said that, it's critical that we should know what its normal anatomy will look like, right? So let's start with condyle. So as you can see, condyle has how many poles? The anatomy of the condyle.
How many what?
Poles.
Each condyle has two. Each condyle has two,
Yes, which ones? Can you name them?
the medial and the lateral.
Yes. So condyle has got two poles, medial and lateral pole. Okay? And then pterygoid fovea, PF, that's where the muscle will attach. What kind of muscle will attach?
Lateral to
So there are two, right?
medial and lateral.
No.
Oh, okay, the superior head is the lateral.
And
The inferior head?
yes. So superior and inferior head, they will attach at the pterygoid fovea, right? Now, this is a different structures or different anatomical variations that you are going to see of the condyle. So, you have medial pole and lateral pole and pterygoid fovea, but at the same time, what you should know is there could be a variation. So here, it's kind of a little heart shaped. Here, more or less round. It's flat, and the same corresponding images are being displayed in the sagittal view. Okay, so that's anterior posterior view, and this is the sagittal view. Yes. So again, you should know the normal anatomy before you call this is abnormal. So for instance, when you're looking at the images, you should know the structures surrounding that, right? For example, here, this particular one, you guys know what is this structure?
Roscoe.
Okay, how about this one?
Acoustic hiatus.
External auditory meatus, okay. How about this one? Yes, how about this one? Okay, how about this one? It's a articular tubercle of the auricle. So now you take that dry skull and try to compare the anatomy here. So here you can see the head of the condyle and the auricular eminence and the glenoid fossa or mandibular fossa. And here is an example of the CBCT scan. You can clearly see that the difference between this panoramic or cropped panoramic radiograph here and the sagittal view demonstrating the CBCT scan. So here you can see the head of the condyle is slightly flatter, right? So could be a normal for that particular picture. This glenoid fossa or mandibular fossa, what you have to see is whether this is intact or not, or is there a thick border here? Because if there is inflammatory lesion, then you are going to see a lot of sclerotic reaction that is happening. So it could be a really big thing. Generally, what I have seen here is like anywhere between 1 or 2 millimeters thick. That's all. So if there is a fracture, possibility is that the head of the condyle can go into the middle cranial fossa because it's being covered with only 1 or 2 millimeters of thin wall. So things have happened in the past. Okay? So here is an example. We talked about normal anatomy or variations. what do you see here? What is so different from the picture that I showed earlier to this? Starting from the top,
The condyle head is fractured.
the head of the condyle is fractured, okay? Hold on to that thought process, we'll discuss that, okay? Anything else?
Isn't it that the walls of the fossa are too thick?
I did not follow.
That the walls of the fossa are too thick?
Yes, yes. Glenoid fossas, the thickness is much more here, right? Earlier, when I showed the normal presentation, it was like 1 or 2 millimeters. This is much more than that. Okay, what else?
Are the two bones supposed to be that close to each other?
Yes, so there is a reduced joint space. Very good. Anything else? Dominic?
Yeah, I mean, it doesn't look very smooth.
No, we are talking our own language.
Yeah. I got you.
He'll be famous next year,
Yeah.
or I'll make him famous next year. Okay, what else? So now let's go back to this image here. So there is a space between the head of the condyle and the glenoid fossa, right? Look at this image. There is reduced space. And there is an irregularity of the head of the condyle. And there is a thick glenoid fossa or the margin of that body. So these are all, when you try or look into those features, these are nothing but degenerative joint disease, also called as osteoarthritis condition. Okay. So when you look at the condyle, what are the things that you should be looking is head of the condyle, glenoid fossa, and the space between the glenoid fossa and the head of the condyle, and whether there is a thickness, how thick is that? And when you are looking at the MRI, so you have to look whether the head of the condyle, when it's open, like it is moving, translation or not. And then in the closed position, it's coming back up. And you have to also check the disc, which we are not going to discuss today. Okay? When we discuss MRI sometime, we are going to talk how you have to look when the condyle is moving, the disc is moving up. Today's topic, no disc. We are going to focus only on osseous structures. So moving on, slightly medial and anterior to the external auditory meatus, you are going to see some cells. So this is the axial view you are seeing. This is the coronal view and the sagittal view. So these are called as, these lines that you are seeing are called as cross hairs. So it will tell exactly where I am checking or where is that I am looking or pointing to. For example, here the patient's right side and patient's left side. So here the external auditory meatus and the canal. This is where it is correlating on all the 3 planes. So MPR view. So this area, this area, this area means the same. That's exactly what is that I'm trying to look. And occasionally, you can also create a custom slice. So for example, if you see this particular line, like this one, you can cut. You can take a slice like this, and then that slice is being displayed on this part. So, sorry. So this is called a custom slice. You can cut however you want. You can cut like this, you can make a cut like this, you can cut like this. So, or slices. So, in the temporal region, you are going to encounter some air cells. Those are not any pathology, or that's not a cyst, basically. So, normal air cells. you should know the head of the condyle, how it looks like. And there are some normal cells in the temporal region. Okay. And what do you know about hamulus? J-shaped structure, okay, what else?
Is that what the medial pterygoid attaches to? Oh, that's not right, okay.
You're right, Brian. You're absolutely right. Extension of medial pterygoid is nothing but the hamulus.
Okay, so,
So there are two, medial and lateral pterygoid plates. So here, this is the, which slice is this one? Coronal slice. Again, this is the vomer bone, this is the sphenoid sinus, medial pterygoid plate, lateral pterygoid plate, medial and lateral pterygoid plate. Yes.
okay, so the condyle or the ramus is like, this is now sitting in this sling,
Yes.
and then that, half of the sling is the hamulus, and then the other half is what?
Now I am kind of getting lost.
Yeah, I'm not completely sure how the condyle, how it articulates vis-a-vis that.
Okay, so here, so you know this structure, right? Silent process. Here it is. Okay, so it should the glenoid fossa where the condyle should be,
Okay.
and this is hamulus here, and here is the pterygomaxilliofacial zygomatic arch, malar process, or your J-shaped structure on your exam that popped up. Okay, so hamulus is the extension of the medial pterygoid plate. So when you slice, you are going to see, and what structure is this one? Concha. Which one?
Inferior.
Are you sure?
Yes.
I'm not sure. It could be inferior or middle one because depending on the slice that you are taking. Yes, I do agree that it is concha. Yes. Okay, generally the sphenoid sinus will look like a single structure, but here there may be a separation. So here it is dividing the sphenoid sinus into right side and left side. So again, the sphenoid sinus generally should be air-filled, until there is some kind of pathology. So this is another view where we are trying to show you the medial pterygoid plate and the lateral pterygoid plate. So here you can clearly see a part of extension. This is the hamulus structure, or hamular structure, this portion. Again, here, what do you think is this structure here? Starts with letter T and ends with fossa. Letter P. There is no pterygomandibular fossa, at least I didn't read in my anatomy class. In Wen's class, probably I'll learn. Pterygomaxillary, facial fossa, that's. So here, P, letter P. Starts with letter P. Oh. Well, I am really sorry because my pronunciation is slightly different because I went to a different dental school. I got trained under British and we did not follow the British, and because we never liked them because they ruled us, right, for so many number of years. Anyways, that's a different story. And then we started our Indian thing, and then we are neither British neither Indian, so a different accent. Okay. I'm trying to learn, but it takes. a lot more training. I'm failing every time. Anyways, here, whenever you are trying to extract a tooth, there is a chance that you have to take into consideration not to fracture the pterygoid plates. So, whenever you're trying to extract this third molar, there is a chance that a pterygoid plate may fracture or the hamlet may fracture. Yes?
Is it really easy to fracture that pterygoid plate when you extract the tooth? And it's- what do you do when that happens?
Just apologize. Just pat him on the back. They're there. I'm sorry. You'll be all right. Suck it up, big guy. That's what I'm gonna do.
So, again, when you get a training how to extract the teeth, one of the reasons that they always suggest is when you're trying to extract, hold the jaw like this, and when you're trying to manipulate, use the forceps like this, like a buccolingual orientation, so that you're not causing too much of damage. And again, this is oral surgeons may hate if they see that I'm teaching how to extract a tooth. So, but my favorite instrument has been periosteal elevator for most of the extractions. If you're, again, based on my own personal experience, if you know how to manipulate, because most of the teeth, they are like straight on sitting in the sockets. If you use periosteal elevator, it has got a nice scoop kind of thing, like spoon shaped thing. So all you have to do is go down at the cervical CHS junction, try to lift. By doing a couple times or maybe a few times, the tooth will pop up like this. So that's what I thought was very easy, but you should know how to manipulate that. Again, oral surgeons are going to hate me to the core. Let's stop further discussion on extractions. So let's focus on here. So when you are trying to extract a tooth, so there is a possibility that the pterygoid plate may fracture. So you have to be cautious, and that's why we are trying to learn how a pterygoid plate looks. And then here, in this particular example, they not only they broke the maxillary tuberosity, and then part of muscle has come up in this one, that's the lateral pterygoid muscle, and lateral pterygoid plate, which is unusual that at least I have not seen in my own personal experience, that fracturing. But in this example, yes, there is a fracture lateral pterygoid plate. So things could happen. So careful. And if you're not confident, don't extract third molars. Stick to the teeth that you're more comfortable. Yes?
For older patients, particularly older female patients, can you tell in a radiograph if someone's starting to develop osteoporosis, or you can't tell that density?
So again, that's a very, very good thing that you brought. Since you brought this, we will discuss a little bit. Not so much, but next semester we are going to. Yeah, to answer to your question, the term that I or radiologists would like to prefer to use is osteopenia, not osteoporosis. Two different things. Osteopenia is because you are seeing less trabecular pattern, and then particle plate is very thin. Then you can say it is leading towards osteopenia. Without having a lab diagnosis, you can definitively say this patient is having osteoporosis. So, to answer to your question, let's say, like here, this band here, especially in the canine premolar region, again, here you are not able to see this portion of the thick cortical plate. If it is less than 3 millimeters, then it is suspicious for osteopenia. Then you would run multiple tests to confirm that portion.
Would that affect your treatment plan for an extraction or dentures? Or does it matter if there's less bone?
Yes.
Would the only problem with pulling out a little bit of the pterygoid plate be if you want to place an implant later on?
let's go into
A lot more difficult problems, medical legal problems. Yes. Yes. Your list of concern is placing implant there. Yes. Okay, so again, moving on. So you may have seen patients with different presentations, right? Or there's a facial profile. So they may have a prognatic maxilla, mandible. So in those conditions, who wants to have this elective treatment, we do something called as Syed fractures. So purposefully we break the maxillary region, and then we try to pull the maxilla forward or push it, depending on the situation, prognatic or hypoplastic maxilla. You can correct those things. So here is a different example where there is an automobile accident, and you can see clearly that the pterygoid plates are fractured. So this is medial pterygoid plate and the lateral pterygoid plate, which is fractured. So this is a different case, but showing the fracture of the pterygoid plate, but in an automobile accident. So when to call Lee-Ford fracture 1, 2, 3, it has to always include pterygoid plates. If you're not going to include pterygoid plates, then it's not the Lee-Ford fracture. So it could be a modified Lee-Ford fractures. Okay. So for this one, Lee-Ford 1, this extends from the alveolar region. It goes like this, all the way to the pterygoid plates. And then here, the orbital region, and then the fracture, they will do it here. And this, generally, we don't do any surgical procedures, but any accidents, there will be crush injuries. So moving on. Here is an example of hard palate that you are seeing. And this is a coronal image where you can see the hard palate intact. Again, there could be an extra bone that is present here, what we call it as maxillary, what is that called? Maxillary tori of maxilla. I'm blanking now. So occasionally you could see that. So here, a slight extra bone that is present. So this is the hard palate that you're seeing. And here is the soft palate. So here is an example. If you see or treat a patient with a cleft palate, you can see that there is a bridge. You can see here, this is the nasal fossa here, and you can see clearly there is a breach. And here is an example. This is tooth number 8 and 9, 7 and 10, they are missing. So there is no alveolus bone or alveolar ridge here. So this is an example of bilateral cleft palate. So if you compare this image here with this one, you can see the teeth are present and there is no bridge. The other structure that I would like to highlight here in this particular slide is incisive canal or incisive foramina, also called as nasopalatine duct or foramina. It is usually running it has got a rail track kind of appearance. You can see corrugated border like this one and like this one in between tooth number 8 and 9. So generally they are pretty straight like this. Exceptions, if you have a cyst, it could be very bulky or it will cause the loss of that presentation here. I'll have next slide to show you an example. Like here. So in this particular example, like here, so tooth number 8 and 9, there is a loss of lamina natura. Again, next week we are going to talk what is the lamina dura. Probably you may or may not know. So tooth is the crown portion, root portion, and root portion is covered by cementum, and there is a pedial space, and next to that is lamina dura. So that is loss. So if you see loss of lamina dura, it's one of the pathologies that you have to start looking in. Again, we are going to not talk about any pathologies in this semester. Our focus is normal anatomy, some examples where you can see abnormality. That's all we are going to present. So here is an example, a clinical example basically. So these, again, remember guys, this is called as crosshairs. That's the guiding point that where the structure or region of interest that we are trying to look. And if you look at this axial slice here, you can see 3 green lines, right? 1 and 2 and 3. So each line will represent one slice here, smaller portion, and then the second one you can see, and then there is a third portion. So the numbers, you can use these numbers as your guiding. So you're 70.18, 71.18. So we made here 1 millimeter slice thickness. So now, if you zoom into this region, so there was some kind of endo or something was done here. They want to place an implant in this scenario. What do you see here? So say for instance, the patient walks into Andrea's office for an implant. The patient is ready to pay $10,000 for single implant. What do you do? Okay.
Would we have to do a bone graft?
How do you know there's enough bone to do it from that view?
Very good. So that's where we have to focus. Yes, exactly. So remember, I told you it is the nasopalatal foramen. If you're looking at that, it's like a rail track kind of appearance, straight up. Do you see that pattern? First of all, that's what you have to check. So if you see here, as you guys noted, not enough bone is present because there's some kind of little divot or defect present. So now, is it enlarged foramina or is it pathology? That's what you want to rule out. So the guideline that we use is, if it's like 6 millimeters, be sure distally if you're measuring. If it's less than that, we will consider that as enlarged foramina. If it's more than that, then it is a sign that you look for nasopalatine duct cyst or incisive tumor.
Dr. Syed,
Yes,
just to make sure, if it's mesodistally less than 6 millimeters,
yes.
the foramina is enlarged.
It is enlarged. It is considered as enlarged foramina. And also what you could do is you can do the aspiration biopsy. So that means you stick needle there, try to aspirate to see if there is a fluid, because cysts are generally fluid filled. Ooh, wow. You guys desperately need a break.
Yes.
2 minutes? Okay, let's make it 1 minute then.
We can't even go to the bathroom. Gotta run.
You got 6 minutes break. So infraorbital foramen. So infraorbital foramen transmits intraorbital nodes and blood vessels. So when you are trying to anesthetize in the premolar region, you could use that region to block, or again, you can go intraorally or extraorally. I did both the ways when I was a student and practicing dentist. Here, sometimes a fracture, blowout fracture. That's what it is called as. So if somebody is going to hit like this, or a ball is going to come and hit the orbital region, so there may be a fracture in this region, the infraorbital region, and then even the nerve and the muscle here. You know what muscle is here? Absolutely no. What is this muscle here in the orbit? It starts with medial.
Rectus?
Yes. And then? Very good. Inferior rectus could drop down like this into the maxillary sinus. So what they do is oral surgeons or the ENT people put a kind of a little mesh here and push the muscle all over out. So during that time, there could be loss of sensations in that region. So again, here is an example of infraorbital foramina that it looks on the CBCD. Again, right side, left side. So this is the maxillary sinus. Do you know what structure is this one? It's located anterior to the condyle. It starts with letter and ends with process. Yes. That's coronary process, this one here.
So the mandible sits like this, not like this.
Yeah.
Okay.
So you have condyle and the coronary process. Yeah.
So, yeah.
The best way would be is to hold on to the skull in your hand, look at these images, and try to interpret. Looking at the image, this image, then it will sync very easily. So on the panoramic radiograph, you are going to see the infraorbital ridge or the infraorbital margin or the floor is like a very thin white line. Again, here this is what you're going to see. So one of the points, if you're going to go and practice orthodontist, is there's something called as Frankfurt horizontal line. So you look at the external auditory meatus and the infraorbital foramen, whether the patient's head is parallel to the floor or not. You use that as a guideline when you're taking an image, extraoral images, cephalometric image. Yes. You have to show it to the whole class after this class. Okay? Dominic is going to demonstrate the Frankfurt horizontal line. Malar process, your favorite one on your exam, right? Malar process. It was there on your exam, right? Right zygoma, left zygoma. But that was with a periapical radiograph. Here is an example that's showing the coronal slice here, malar process here. I skipped this one because when I write my report, this is all I'll look at multiple things. So you guys are not there yet, so I skipped this slide, that's all. So maxillary sinus, it's air-filled one. Unless there is some kind of disease process, it generally is radiolucent. When we are using the terminology for CT or CBCT, we use hypodense or hyperdense, like radiolucent, radiopaque, hypodense, and hyperdense. So, because we are dealing here with the densities, not with the so much radiolucent or radiopaque. So here is a very good example to demonstrate why you have to know about normal anatomy of maxillary sinus. Here, as you can see, this particular image, the arrows that are pointing is showing that air-filled maxillary sinus. Whereas when you compare this image with this, you can see there is thickening. And what I want you to observe here, there is a tooth and there is some white-like material, or also called as hyperdense. That means there is a crown, artificial crown that is placed. Okay? And at the apex, you can see there is a black area, also called as hypodense region. So, generally, you're going to see the lamina dura surrounding that. There is a breach of lamina dura there. So, and there is an extension into the maxillary sinus. So, as a dentist, you are responsible to treat this tooth. So, the treatment here you're going to do is either extraction or endodontic treatment, or extraction and then implant. Yeah. Those are some of the choices. So, moving on. You have some question?
I just feel a little confused about everything that we're learning.
Well,
The last slide, we need this.
well, don't worry. The best analogy that I would like to use is once you've got your car or a driver's license, you started driving and you felt that everybody was crazy because they were going at 25 mile, 30, 40, something like that, or on 60 mile, 90 or 100. Now you do the same thing because you got experience, right? No?
Yes.
Right. So, because this is the first time you're getting exposed here, there is a lot more material that is present here. Yeah. The whole idea is, can you integrate a little bit of anatomy, and when you look at the anatomy, can you look at CBCD and correlate? That's the whole idea. So, in exam, I'm not going to ask you about minor things. For example, here, the arrow that is pointing out, I'll ask, what is that structure? That's the osteo. That should be your answer. That was your last year's question, so this year I'm going to change. So there won't be an osteo question for this year, definitely. So again, the importance of osteo, let's talk about that. So don't worry, you'll get to the point that you will know everything. So that's why we have 4 years, not just 1 year, right? So these are like connecting dots. So you got some information here. Next year we'll discuss something, so you have to start connecting. And third year we'll start connecting. Oh, it will make sense. Oh, that year that guy told something. Oh, now it does make sense. Now it is like taking your before your road test. You take some stupid questions, right? Before you got that license, written exam, like hydroplaning, this hydroplane, something like this. Now, on the snow road, when you're driving, oh, hydroplaning, or it's raining, or first season of rainy day, you have to be careful hydroplaning because while slates on the road, you can drive too fast. Make sense? Well, I don't know whether it's making any sense, but I'm trying to correlate a few things. Okay, coming to here, the nasal septum and the lateral wall of the nasal fossa, or this is also medial wall of maxillary sinus, right? So maxillary sinus, in the maxillary sinus, the mucus will be there. So mucus will circulate. The way it circulates in the maxillary sinus is like this. So, well, one of the reasons that I put this diagram is because if you are going to see older patients in 1960s and 70s, what at that time the researchers and the clinicians thought the mucus walls, because of the gravity, mucus will go like this, and if you create a vent here, and they are treating the mucosal disease or mucositis. So in some patients you can see a window or cut at the lateral wall of the nasal fossa region. So don't get confused there with the pathology, but that was the surgery at that time they thought it was appropriate. Then they learned over a period of time that mucus is going to circulate like this. So now they are going to create a window here if there is mucosal blockage or maxillary sinus blockage. So here is an example. And one thing that we always look is that whether the ostium, that the opening, just slightly above the middle turbinate and then maxillary sinus, the passage is called as ostium, is patent or is it open or not. If it's not open, then it suggestion that there is a sinusitis or there is some blockage. Then they have to go there clinically and clear or create a window so that the mucus will be clear. So example here. Here you got a right maxillary sinus. And here you can see this is the left. And you can see the soft tissue thickening. And the ostium is not patent. You can clearly see that the ostium is not open, so the patient will complain of sinus problem or sinusitis. So now, the question or why you should know is, as a dentist, patient will say, I have pain in this region. Is it a tooth related or is it sinus related? You have to differentiate. How do you differentiate? Look at the scan. And when you look at the scan, you can see, okay, the teeth here, they are intact, there is no dental caries, and the maxillary sinus, the flow is intact here, so that means it is not a tooth problem or odontogenic problem, it is a problem with sinus. So that means you have to refer this patient to ENT and they'll take care of it. Make sense? So when you are differentiating whether it's a tooth-related problem or is it something else. But patients will just say, I have pain in this region. Yes?
A few slides ago, you showed us a picture of a tooth with a crown on it.
Can you talk
A
a
few
little louder?
slides ago, you showed us a picture of a tooth with a crown on it, and
Uh-huh.
it had inflammation inside the maxillary sinus. How do you know which side of the mucous membrane that inflammation is?
So again, I'm just putting a slice here after looking through multiple slices. Then I was confirmed that it's not a tooth-related problem. You have to rule out. That's why you have to check the whole slice, whole volume, to
Okay.
confirm.
So from a different view, we'd be
Yeah.
able to tell if it had, like, does that happen? Does inflammation move from the tooth side into the
Yes,
side?
yes,
Okay.
yes. So that's one of the reasons that I'm telling you have to look at the volume completely.
Okay.
Yeah, you cannot just say, okay, looking at this slice, okay, I'm confident that this is not a tooth-related problem. No. So that's one of the reasons I'm telling here is you have to look at what are the things, possible reasons that you could see, and how to differentiate from tooth versus other. Yeah.
You said the left side, you said the bone breaches in and it grows into it?
No, there is no breach here in this particular instance.
Okay. So the gray space is very soft tissue?
That's a soft tissue here.
Okay, so it expands?
So here, you can see, this is part of the bone, like here. You can see the density is different compared to this one. So we know that here there are lots of muscles. We can compare this density with this one. It does simulate similar. That means you can say, okay, there is some kind of soft tissue. It's not bone. Because if you see something like this structure here, then we can say it's bony growth.
Okay. And what did you say causes that again?
It could be because of allergies or bacterial infection or fungal infection, anything.
So would it go away on its own or would it?
So there are certain lesions that they go away on their own. we'll talk about, or maybe I may have given a flu in a different lecture, maybe, I don't know. So here is another example where you can clearly see that the ostium is completely blocked. Here, you can see the ostium here, it's patent, right? Can you say the same thing here? No, so that's what I want you to check, whether the ostium is patent or not. Okay, here, this is, I'm stretching a little more here to explain the thing that if you see a tooth with a dental caries, like here it is, and there is a restoration here, or a filling, you can see a white line, right? So that white line is nothing but the exudate that has come from the pulp or from the tooth into the apical region, and the lamina dura has pushed like this one. That white line presentation tells you that it is related to a tooth problem. It's not a maxillary sinus problem. So here, as a dentist, you are going to take care of this. In earlier instance, you are going to refer that patient to ENT. Okay. So here is one more example to answer to your question. Here you can clearly see a dome-shaped structure in the maxillary sinus. Do you see that white line here? Do you see?
Oh, from the tooth?
Yeah. Do you see a white line covering that? No. So here, if there is no white line, so that means it is not related to somebody's phone is ringing.
I think it's the computer, honestly.
It's telling me to get out? No, still I have time. Okay. Here, because we are not seeing that white line, so that it means it is not a tooth-related problem. Again, if it's not tooth-related problem, you could refer this to ENT or to a oral surgeon, and you don't have to treat. In this particular instance, because there is no white line, and we can, by knowing, just looking at this shape, it's a dome-shaped structure, we call this as antral pseudocyst, or also called as mucus retention cyst. So what is happening is, you know, imagine this is the floor of the maxillary sinus, and there is a mucosal thickening that is covering, that's called as Schneiderian membrane. And then, because of some allergies, here the mucus start accumulating in between, and it grows like this. It forms a dome-shaped structure. It most likely is because of allergies, and then you are going to see this kind of presentation, especially if you take a pan or a periapical radiograph during the spring. And when you take one more PA, during summer it would have gone. So it clearly tells us that it's because of the allergies. So for this, we don't treat this one. So you got three different things, just looking at the maxillary sinus. One is sinus problem, then you are going to refer. If there is a corticated border, white line, you are going to treat. Here, it's neither of our problem, neither ENT's problem nor dentist's problem. But you should be able to recognize what is this. Now moving on, ethmoid air cells. So ethmoid air cells are generally, again, they are air filled. They look like something like a partitions within the box. So ethmoid sinuses are divided into anterior and posterior, and apart from the inferior turbinate, basal lamella, you can divide the ethmoid sinus into anterior and posterior. Some interesting anatomy here, or variation. So these are all ethmoid air cells. This particular one with maybe a red here, sometimes the extra layer or extra cells that are present below the inferior orbit is called as Haller cells. Please do not get confused with the cystic lesion. It's a variation of normal. So that's an example of Haller cells there. Oh, this one and this one.
So the air spaces?
Yes, air filled. Again, when you look at those, they look like cysts, multiple cysts. Please do not get confused. So it was variation of normal. Let's move on with the sphenoid sinus. So generally, sphenoid sinus again is one single sinus that is air filled. Exceptions can be like here, in this case, this septation that is present here, it could divide into right and left. Here, this is the coronal slice that you're seeing here. This portion is the sphenoid sinus. And this portion, what you're seeing is the internal carotid artery. So here the common carotid artery will divide into external and internal and goes into the brain. Well, it's still called as internal carotid artery, but there may be some calcifications. So if you see those calcifications, then you have to check again for the calcifications in the neck region. Patients may end up getting stroke. There are a few instances where there were calcification and the patient had very high blood pressure, and because of the high blood pressure, these calcifications broke into finer particles and caused either cardiac stroke or ischemic stroke. So that's the concern or clinical concern that you may encounter. The other sinus is frontal sinus. Again, this has air-filled one. This is how it looks like. And the mucus within that circulates. The most common or dental related thing that we could see is osteoma. That means a hard bone-like structure that you're going to see in the frontal sinus. Again, we are not going to treat this one because it doesn't cause any more problems unless it is growing, outgrowing from the sinus and it's cosmetically if it's causing some problem, then we do cosmetic surgery, that's all. So otherwise, osteomas in front sinus, generally we don't treat. We talked about maxillary tuberosity, right? So you have to be careful not to break. Here is an example, yes?
Are osteomas likely to only become malignant?
No, no, at least I haven't seen, so.
Okay.
So, oma, so that is the benign one, so. So here is an example. A case came from periodontist. They were unable to figure out that there was a sinus discharge. That's the chief complaint. And they wanted to place an implant in this region. So this is 11, 12, 13, 14 region. So, and then when I looked this one, so here is a very good example, Madeline, like you asked in different, why do we need to see a different slices? If you look at that particular first slide, you can see intact walls of the maxillary sinus. Whereas you go down, you can see there is a breach missing, right? So that's, if there is communication between oral cavity and the antrum, we would call as oral antral fistula. So this is an exaggerated form of oral antral communication. Here you can see, compare this side, right side, you can see the floor of the maxillary sinus is intact, but whereas here you can see up to here it is intact, and here it is present, but here it is lost, right? That's lost here. So that clearly tells us that there is a communication between antrum of the maxillary sinus and the oral cavity. Is oral antral communication. Now, this could be called as oral antral communication, or since there is filled with soft tissues, sinusitis, associated sinusitis. Make sense? So nasal fossa or nasal septum, it's a thin, straight septation that you are going to see. As we move posterior, then you are going to see more bone. Sometimes the septae or nasal septum can be a deviated one, like this. And we talked about turbinates, and you guys are familiar with the turbinates. There are 3 turbinates: inferior, middle, and superior turbinates. So sometimes you are going to see a the middle turbinate air-filled region, like this one. This is called as air-filled middle turbinate, also called as concha bullosa. Again, do not get confused with a pathology or a cyst, like Haller cells. This is also a variation. Concha bullosa is a variation. So here you can see bilaterally, concha bullosa here and concha bullosa here. And this one is Haller cell here. Some of the mouse is not working properly, so the lines are going here, there. So that's beyond my control, sorry. Maxilliofacial. We talked about this one briefly. So here you're going to see maxillary artery. And it's a teardrop shaped structure. I think I put a video, right? In that video you have a discussion, a little more discussion. Zygomatic arch. If there is a fractures or automobile accident, then you can see the fracture of the zygomatic arch happening. What they do is, depending on how bad the fracture is, they could use simple periosteal elevator to pull it back, or if it's completely fractured, then they do surgically and repair. So moving on, so we only were able to complete maxilla. Now we have mandible, cervical anatomy. And we have 15 minutes, right? Not really, 13 minutes. Okay. So we talked about condyle here. Showed different presentations. And just anterior to the condyle, you're going to see, if you're looking at the axial slices, like little tips of the bone, that's the coronoid process. So why do we need to know about coronoid process? When we think of a condyle, the patients will generally complain that the patients are unable to open their mouth or close properly. Here is an example where there is a coronoid process that is hyperplastic. So this is the zygomatic arch that, come on. From here, if you measure, if it's more than 1 centimeter, then we would term this as hyperplastic coronoid process. So what is going to happen is, imagine this is the zygomatic arch here, and there is coronoid process generally way down here. So if it is like this, and the patient is opening or closing, so patient is opening, it will come down like this, and when he or she is closing or trying to close, it could get long. So this is a problem. So example here. Sigmoid notch, or it's a depression between condyle and coronoid process. Ramus, I'll skip this one. What I can talk about ramus is ramus, right? Styloid process. So occasionally you can see a ligament that is getting calcified from the styloid process to the hyoid bone, also called as stylohyoid ligament. Remember, this stylohyoid ligament, the term, occasionally most of the clinicians, they prefer to use Eagle syndrome. That's a misnomer. I wanted to take a second to rectify that or clarify that. You have to check clinically this particular patient, and when you ask the patient to turn head like this, so what is going to happen is, because of the sharp structures that are present or ossification, patients will start complaining pain. Only then you would refer the patient as Eagle syndrome. not as soon as you see the calcification. So here is an example or exaggerated one, so you can see ossified structure. Again, as soon as you see this, please don't call the patient as having Eagle syndrome. No. Then, I think I may have a few more slides. I think I should be able to finish on time. 2:49, right? I told? Epiglottis. So this is area that you may have to check for posterior carcinomas in this particular region. So most commonly, that's where hidden carcinomas are going to occur. External oblique, it appears like a very thick or white line. So certain carcinomas or malignancies, they are going to destroy that, this whole external oblique edge. So then you have to be suspicious, and it's the time that you have to refer that particular patient to an oncologist to treat. Genial tubercles. Here is an example of a lingual foramen. Please look at this image carefully. Do not get confused with fracture. That's not a fracture, but it's a lingual foramen. So when you try to place an implant in that particular region, please make sure or cognizant of the anatomy that is present there. So people say that anteriorly, not much we have to take care of. That's true, but exceptions like this will be there. So if you try to place an implant that is longer, and if it's going to hurt this lingual foramina, because there is a lingual nerve there, then patient will complain of paresthesia. And hyoid bone. Inferior alveolar canal, or inferior, like this, this one is inferior border of the mandible. When you are evaluating, try and see that this is at least 3 millimeters, because if it's less than that, then we have to consider the patient having osteopenia, as Brian asked that question way before. So here generally we check, and it's less than 3 millimeters, then it is suspicious for osteopenia. So internal oblique ridge or mylohyoid ridge, that's where the mylohyoid muscle will attach. So it's when you're looking in a two-dimensional image, one appears like superiorly, the other one looks inferiorly. So external oblique ridge and then internal oblique ridge. Inferior alveolar canal, when you're looking, you have two borders here, superior border and then inferior border. So occasionally you may see multiple branches or bifid canals, like here. In this particular example, you can see 3 mandible foraminals, 1, 2, and then 3. And here, there's a branch that is coming here and going back. Now you could ask me this question, why do we need to know? So if you want to place an implant in this region, if you're going to put an implant in this region, you're hurting the nerve and the patient will complain of paresthesia. Say for example, in this particular instance, if you want to do apicoectomy, so that's a procedure that if there is an endofailure, what they do is they open up here and try to cut a portion of apex and do retrofilling, meaning to say that they put the amalgam filling there. So you should know whether you have one mantle foramen or multiple of those. So here is an example of shoe or bifid canal. So you can see one superiorly, the other one is inferiorly. There's 2 canals. So why do you care? Is because if you think the canal is starting here, and if you don't take this into consideration, If you place an implant that is going beyond this, then you are causing paresthesia. Your mental phenomena, you have to know. Usually they are one. And again, this is an exception. Occasionally, the inferior alveolar canal comes and ends here at the mental foramina. Occasionally, it can go back like this. That's called as anterior looping. Again, these are the variations when you try to place or do some kind of surgery in that region. Make sure that you understand the whole anatomy, how the anatomy, is there any variation? The other structure is submandibular fossa. Again, importance here is because there is kind of a little defect here. If you place an implant like this, longer implant, you could be impinging on this salivary gland. So either you have to orient the implant like this if you're going to use a longer implant. So that's the clinical significance here. Again, when you are using pan as an example to check for the bone, here, as we discussed earlier, you can see on this particular pan, you can see there is good amount of bone, but as you look through the slices, the buccal bone is very less in this example. Here. So please do not depend too much on your panoramic radiographs. So we talked about spaces, right? Air spaces. You guys are familiar. Glossopharyngeal and then nasopharyngeal. Nose. Palatal glossal air space. Talked about soft palate. Yes, we did. Talked about tongue. Yes, we did. That completes our CBCD normal editing. Oh. Couple more minutes. Just a kind of review session here.
There you go.
Which one is this? A. So that's the answer. So yes.
I don't know if it matters or not, but in vascular dynamics, we always call this view horizontal.
No.
But here we always call it axial. Is that the same or are they two different?
Axial is the preferred term. Horizontal we don't use at all.
But it does mean the same.
Horizontal
Yeah.
is the plane, not the vertical.
Okay. That makes sense.
Come on, guys. You don't want to go home? Coronal, okay, yeah. Anterior, very good. Left side is the answer, okay. Medial, very good, very good. Okay, very good. Very good. Okay, very good. Nasal septum. Okay, 5 more minutes, okay. I left 5 more minutes earlier, that's what.
Thank you. Happy Friday.